Okay, it's my pleasure to introduce the session. Today we're going to be discussing pushing beyond today's frontiers in CT analysis. This session is sponsored by Medis Medical Imaging. We have 4 speakers, and then we'll have a little time for Q&A at the end. So we'll just jump right in. Our first speaker is Joao Cavalcante. He's a director of MR and structural heart imaging at Alina Medical in Minneapolis, and will give us our first talk this morning. Joao?
Well, thank you so much, Matthew, and thank you everyone for being here this morning. I really appreciate the opportunity to talk to you a little bit about the work we have been doing, and many others as well in the field of cardiac CT, assessment of myocardial strain. All right, I'm going to swap here. So thought about dividing into these 4 topics in the short time period of 10 minutes, but give you a little bit of the background, why a strain and what is it? How do we use that clinical practice, as well as how can we do that with CT? And also some potential clinical applications in the future. So we want to talk about strain. Strain is that formation of an object normalized to its original shape. And the strain rate would be the change that it takes over the period of time. So if you have the strain, and divided by the time, you have the rate of strain, or strain rate. So let's take a look at this myocardial fiber. You can see that over the cycle, it shortens. It shortens in its longitudinal axis, but it also thickens across the radial axis. When we talk about strain, then if we have that original length, and we then know what's the final length, and if we do that math, we will have a shortening of 28%. So because of shortening, we're going to do it negative, so minus 28%. The more negative, the better. Now, the heart is a bit complex because it's not only the longitudinal aspect of it, but it also has a radial thickening, as you saw, as well as a circumferential. Now, putting all together, it almost looks like that, like a wet towel. So the heart really shrinks longitudinally, it thickens, and also has that circumferential strain. So, and in between these 3 layers of strain, or these 3 directions of strain, you have what called also the intersection, the amplification, because they multiply. You can do that, and that was started actually initially with CMR tagging, as you can see on the left side. Obviously, that requires a special sequence, and you can see that these dots, they form over the period of time, but they are not consistent. Reproducibility was difficult and also very tedious. Echo speckle strain is the one that we are talking about that have been used in clinical practice in many, many centers. You have to have good image quality. The computer does the automated tracking, and has been great work about the learning of that. Through CT, all you need to do is having a good acquisition that you can finally then do this, what we call feature tracking. So if we know where the endocardial border and the blood pool is, we can track that line and see how much it shortens in all the directions. If we integrate that, then one can do, finally, the 3 layers of strain. So why strain? In addition to the definition, why do we need to bother and measure that? Well, ejection fraction, as one of the most important parameters that we measure in clinical practice, may not reflect the myocardial damage, even when it's quite early. So take a look at this graph, which represents that. If we want to diagnose, for example, heart failure preserved ejection fraction, we need to have the ejection fraction, we need to have the symptoms. But there might be already myocardial signatures and differences upstream that one can detect, not by ejection fraction, but rather by this diastolic relaxation, or even by abnormalities in the longitudinal strain, which are the layers that are the most vulnerable over the period of time. Put into clinical practice, after you assess that strain, you can see that there are cutoffs. The more negative, the better, because you're going to have the more shortening. But you can just take the minus sign and just say, okay, the greater the number, the better. It makes the same sense. But you can see that across several strata of ejection fraction, strain can have a signal. Now, how can we do that with CT? You got to have a good scanner. It's important to have good temporal resolution, particularly if we're going to do that, obviously, in patients that have cardiac arrhythmia, patients that have valvular heart disease, and obviously have a capability to have a good Z-axis coverage. Now, during the strain analysis, I will not have the time to play this entire video, but basically you have the full 10 or 20 phases data set, retrospective acquisition. You align the crosshairs, you can construct then finally the 3 planes, the 2, 3, and 4 chamber, and then after that you can then deposit these dots. You can do the endocardial or just the endocardial with epicardial in both systole and diastole. You propagate, and whenever you propagate that, you can then obtain the values for the strain, and you can see how it tracks, so on and so forth. How does that work comparing to echo? So this is work from Dr. Bach's group from Leiden, showing that there is a very good correlation between CT against 2D echocardiography speckle tracking, perhaps slightly mean a little bit higher by CT, but not substantially different. There's slightly differences between modalities, and we need to understand that because volumes are different and perhaps even ejection fraction. So now looking at differences, for example, even in this patient that has hypertrophy, aortic stenosis, preserved ejection fraction, yet abnormal strain. You can see here that the strain separates patients that have a more positive strain closer to 0 do worse than those that have preserved strain, despite having normal ejection fraction. And this is reproduced over and over and over. So you can say, well, ejection fraction when it's below 60, I can already tell the prognosis, but strain still has a signal there, even more so if the ejection fraction is preserved. Now, as I mentioned before, you got to have good image quality. Visibility for echo strain obviously is reduced. If you cannot do it, please don't do it. If you cannot see it, please don't do it. Echo strain before CABG can be not feasible in almost 47% of these patients. And that's why CT strain, when we see now prognosis coming from the group also from Leiden, and also from our group showing in this prototype, using a 64 single slice CT scanner, a good correlation between echo and CT, and outcomes as well. This is using single source 64, and you can see that the outcomes were dictated not by the ejection fraction, but rather by the strain. We can do now with dual source scanners, and you can see a much better temporal resolution there and a greater visibility, 97%, which obviously is not only about seeing how it tracks in all the chambers, but also it has a prognostic signal with a very similar threshold with echocardiography here, adding incremental risk factors to the clinical risk score as well as ejection fraction. This is work by Miho Fukui, who is here with us in the audience as well. Not only at the baseline, but even also after you fix the valve, what happens with the strain? Here's a patient that had severe stenosis, has received a SAPIEN 3 device, and you can see that despite having a normal ejection fraction, the strain has not normalized. These patients without improvement of the ejection fraction also do not do well, which might be another signature of how sick the ventricle has been for a long time. Can we intervene before it changes or even before symptoms? You can do this in other patients too. This is a group of patients with functional mitral regurgitation that also has a prognostic signal. You can do this also in patients with tricuspid regurgitation, RV dysfunction, because now you have all the chambers. This is not MRI, this is actually CT, RV free wall or RV global longitudinal strain. The RV is important when we talk about the aortic stenosis. This is work also by Miho Fukui looking at how does the CT evaluate and detect RV dysfunction. Echo, we have 3 parameters that sometimes might not agree with each other. You have TAPSE, you have S prime, you have fractional area change, and you have by ejection fraction by CT. 500 patients, and what we saw is that in about 25% of these patients, 1 in 4 patients that were called to have normal ejection fraction, actually, let me rephrase, normal RV function by echo, because 2D echo cannot give you ejection fraction, right? So normal RV function. They had RV dysfunction by CT with the EF less than 50%. And so in the outcomes were dictated by what the CT had diagnosed, not what by the echo had picked up. You could finalize to say, well, I could do global longitudinal strain, and that is a marker of fibrosis. Just let's wait a second. It could be for replacement fibrosis, but not by the diffuse interstitial expansion that we see with elevation of ECV. Here you have a nice correlation between GLS and ejection fraction. As we talked about before, it correlates, particularly in patients with ejection fraction that is preserved. We want to see this spread, because patients that have a worse strain are the ones that are more vulnerable. But when you look at GLS against extracellular volume, there was no correlation at all. So they are representing in reality two completely distinct domains. One is the function and one is the structure. And we need to understand both, because once you have abnormalities on both domains, that's when you do worse. And putting it all together, this is a recent work as well showing that there are important markers: strain, LGE, and expansion of ECV. The more abnormalities you have, the worse you do, particularly in patients with low-grade AS. Moving forward, CT ECV, even though that's not the topic, our group is working on that as well. Can we do that? This is work by Hideki Koike here in the audience as well, and presenting today, showing that that's feasible by CT, and we can learn quite a bit about. And why is that important? Because by MRI, you can see that there is a stratification of risk, not only for all-cause mortality, but cardiovascular mortality, once there is elevation of that ECV, which is another marker of outcomes. And ultimately, the highest elevation of ECV would be those that have cardiac amyloidosis. And this is a recent case from our group, a patient that had a SAPIEN 3 in 2020. You can see that he came back again, filling with heart failure, preserved ejection fraction. You can see this paravalvular leak. This is by late GAD. You can see the mid-wall fibrosis, hypertrophy, and elevation of ECV, 37%. And by CT, the ECV was high as well. So the correlation between the two modalities, which is quite important, and confirming with technetium pyrophosphate. So triple pathology: severe AS, treated with TAVR, cardiac amyloidosis, and now severe paravalvular leak. So in conclusion, I think that TAVR CT can provide us much more than just the annular measurements and the current assessment that we do for the axis. CT strain might be an important role, and as well as the development that myocardial fibrosis could be by CT. With that, thank you so much.
Wonderful, thank you so much. So our next speaker is friend and well-known to all of us, Dr. Jeroen Bax. Professor Bax, I met, I think it was 2008. He was given an award by the American Heart Association for being a young investigator award at that time. He already had like 600 or 700 publications. I think he's probably now up to about 2,000. Past president of the European Society of Cardiology, and just an incredible imager. He's from Leiden in the Netherlands, and just prolific and a great advocate for CT. So please, Jeroen.
Not really sure what to say after all the things that you say. So I have a position in the hospital where I work in a university, and I do partially clinics, like we all do, but I have a large time where I build research. So what I built over the years is sort of a school for people who come from other countries mostly, and they want to do a PhD. They want to go through a track of 3-4 years, and then they dedicate themselves to research. So I got about 20 of those people, and I have a team of people who guide these people through these PhDs. And with that, they publish, and that explains to some extent the numbers we make. But I must say, it's quite fun to do that, because it's very rewarding if you see that you can take people to the next level and they go back to their places. And now we build with these people that are all over the map, if you want, sort of consortia. And they can still keep doing research, although in their places it's non-academic, so they have to work hard, but they can still contribute to things. And for them, that is something really, triggers them to not purely work clinically, but also keep on doing research. Let me see if I can get this first slide here. I don't have any connection. Is that? Oh, yeah. Right. It's quite early for me. Sorry about that. So I was supposed to talk about this rather complex topic. I enjoyed the talk by Joao, and that's the things that we have been doing, and we make steps forward, but we also go in directions like he showed, the thin fibrosis in the ventricle. You cannot see it. You have to rely on numbers. If we go in the direction of AI, we have to go even more in the direction of numbers, and we don't see pictures. I like to see pictures because I have an idea what I'm doing. So I took a couple of statements from other articles. So what is it all about this? This is about vascular inflammation. So it's really a step further than we have always been doing. And it's not so much a step further, but it's a step earlier in the disease. So what is happening in the coronary arteries and in large vessels as well? This vascular inflammation plays a very important role in the development and progression of coronary atherosclerosis. So if you want, is an early precursor of the atherosclerotic disease. The earlier we come in whatever medical pathophysiology, the higher the likelihood is that we can do something good for the patients. The way we work, I look at Joao's beautiful work, but you speak about patients that are end stage. They have tricuspid regurgitation, secondary to RV dysfunction, secondary to LV dysfunction, secondary to severe MR, and then we come and we put a clip. Yeah, the patients improve in symptoms, but we're not doing anything on longevity. So I think if we want to make a step forward in medicine, we have to go earlier. One good example is the PROGRESS study from Edwards, where we put now a transcatheter valve in half of the patient group at moderate aortic stenosis before they become severe. Because as Joao showed, a lot of the stuff that happens in the coronaries or the valves starts as a ventricular problem. There's all this fibrosis. So we come earlier, we actually have a chance to do something. So detection and quantification of vascular inflammation is what it's all about. And this may assist in early risk stratification of coronary disease, probably, hopefully, before development of coronary plaque. You know what Novartis, for example, is doing. They push all these medications that work on inflammation, the smart drugs, if you like. In the last years, we've seen a lot of development in that. And the hope is that if we can give them the targets, they can do the treatments. So inflammatory cytokines change the characterization of this pericoronary adipose tissue, because in the normal individual, it's also there. It inhibits lipid accumulation and adipocytes differentiation, and CT can detect these changes as an increase in CT attenuation, Hounsfield units, and the more minus 190, I always get confused also with the strain, minus and positives, etc. But minus 190 is good, and if you go in the direction of 60 minus, that's bad. Then you start to get inflamed tissue. This is what it looks like. I think this is a very nice graph. Healthy conditions on the left. Yeah, on the left. So the red is the vessel. You see the PVAT, pericoronary fat. And these are nice big cells. And so what happens under healthy conditions is that the perivascular adipose tissue exhibits anti-contractile and anti-inflammatory properties in response to the enemies that are coming, the markers of oxidative stress and inflammation. So under inflamed conditions, when we go to the right, these big cells becoming small cells. Under inflamed conditions, the PVAT undergoes unique phenotypic changes due to vascular inflammation. And the hope is, if that we come with these smart drugs, that we can interfere in this process. But then we need something to show it to us. So that's where the imaging comes. So under inflamed conditions, this PVAT undergoes unique phenotypic changes due to the vascular inflammation compared to non-perivascular adipose tissue located from the vessel wall. Here you see visualized what that looks like, because it doesn't look like that if we see it, but the imaging companies make it possible that we start seeing it. On the left is panel A, that's what a normal situation would look like. On the right is panel B, that is what an inflamed situation would look like. So the Hounsfield units are going to go from minus 200 or something in the direction of minus 60, 40, and so on. And that is where there is significant inflammation. And this is the pictures that you see. I think this is a difficult one to work with, right? Because we're very used to looking at the focal local stenosis. And now we have to think differently. So this is not a target for whatever intervention or so. We're not going to do PCIs on these patients. But if it would work with the novel medications that I just indicated to you, then we can select the patient based on this sort of softwares. and send them for the medical treatment, early treatment, because these drugs are not cheap, as you know. So this was the CRISP study. I think beautiful thing. When I read it for the first time, I had to read it 5 times before I understood what it was really all about. It's a post hoc analysis in 2 prospective independent cohorts, one coming from Germany, one from the United States. The one from Germany is from Stefan Achenbach's group, and it's just consecutive patients undergoing coronary CT. So the primary objective of that was to look at the predictive value of perivascular fat attenuation, PFAT index, for 2 primary endpoints being all-cause mortality and cardiac mortality. And when they incorporated this PCAT in sort of an algorithm, they were able to make a difference. These were the pictures that I just showed you. So you can measure that like that. You can measure it in the different vessels. What you see here is that you got different softwares. This software works with taking little pieces. Eventually, I think, little pieces, as you see on the CT scan, is working where there is already stenosis. That's not what we want. We want to go earlier. So we want to go earlier. We're not going to look for stenosis on the CT scans and then do this analysis. We're going to take vessels where we do not see much. And this study actually showed that these fat attenuation indexes of lesions that were already visible there on the RCA and the LAD were associated with all-cause mortality and cardiac mortality. And then there was a problem because the circumflex somehow didn't work. When we work now with the MEDIS software, we don't find that problem. We see that we can do in all different vessels. So this is, of course, the most important. These fat attenuation indices, they were related with outcomes, bad outcomes. So that's where we want to go. And if they then do the maths, then they see that the receiver operating curve, that it's better when you do that FVI than when you do the routine stuff. So the conclusion is the perivascular fat attenuation index, when measured around the right coronary artery, specifically the right, predicts all-cause mortality and cardiac mortality over and above the current risk stratification as we do it. So the integration of this may give us a new tool to treat patients earlier. So this is what we have been doing so far when working with MEDIS. I know Hans Reiber very well. He lives opposite of the university, and I see him on regular basis. So when I learned about this, I said I would like to go into this, and I would not like to do just one spot. I want to do the whole vessels. So higher peak attenuation in the direction going in less minus, so from minus 160, 190 being normal to minus 30 or so, is associated with plaque characteristics, non-calcified, mixed. So we started with that. We started with the routine stuff, where I see something on the CT, and I know, because we published so many years for the first time, that a non-calcified plaque in 2007 in JACC, we were doing a care track, because we didn't have a fast track chest pain unit. So what we did when the patient came in during the day and they didn't have an infarction, they just had an ECG that you didn't feel comfortable, they had complaints, and we did a CT scan with them. And if the CT scan was positive, we took them straight in the cath lab, only during day hours because we could not do that at night. And we didn't have like what you have now, this where you can do an exercise test, etc. So we did it with the CT. And with that one, when we put these patients in, I saw for the first time that really these non-calcified plaques in those patients that were positive were extreme. There was almost hardly any calcium when they came very young. So I think then you go earlier in the disease. So that is the state where we're looking at here. So PCAT in patients with ACS versus stable CAD. ACS, unstable disease, more inflammation. PCAT closer to, let's say, this minus 30, minus 50. And stable disease, lower PCAT, more in the direction of 190. So we looked through our database, what we have, 2005, 2015, and we selected out the patients that after the CT scan developed within 2 years, maybe you say that's a pretty long time frame, maybe yes, maybe no, developed a non-STEMI or a STEMI or an ACS, and were hospitalized for that, and we have the information on that. And we compared that with patients with stable CAD for the moment, so I'm not going down yet to the level where there's nothing that I can see and work with that, with medications or so. So we did a propensity score matched 1 to 2 for age, gender, Cardiac risk factors, as indicated there. Excluded were the patients with previous revascularization, because then the whole interpretation becomes difficult. And this is what it looked like. So here you see the STEMI ACS in red, you see the non-STEMI ACS, and you see the unstable anginas. And all of that goes in the direction what we just spoke about, not to -30, but to -60. -30 is extreme, and it depends also on the vendors that you have, it depends on a lot of things, but you see that the STEMI ACS go lower, so more damage than the non-STEMI ACS, and the unstable anginas have the least. I don't have a conclusion. I cannot say where this is going to go, but I have the hope that if we team up with pharma industry, and we can start working on these things and better define these patients, that we can come with earlier treatment in the hope that we at least partially prevent what we are still treating nowadays. Acute infarction, an ischemic lesion, etc. Thank you very much.
Thank you. Thank you so much, Jeroen. So our next speaker is Marton Kolossvary. He comes to us from Semmelweis, then Hopkins, then Mass General. He's probably one of the most educated of us. He's working on advanced plaque metrics with cardiac CT, and really a rising star in this field. It's a pleasure, please.
Thank you so much for that very kind introduction. And good morning to everyone. I would like to talk about one of my passions, about advanced analysis of coronary plaques using coronary CT. As we all know, the presence of coronary artery disease is predictive of later outcomes. If we dichotomize our patients with no CAD versus non-obstructive and obstructive, we see a clear differentiation based on clinical outcomes. But we can go one step further. We can also talk about how many vessels are affected by CAD, to what extent. And we also see a gradual increase in MACE rates with increasing severity of coronary artery disease. But still, there's so much more information on the coronary CT scans. We can also describe coronary artery disease using adverse plaque characteristics, such as low attenuation, positive remodeling, or the napkin ring sign, or spotty calcification. And multiple studies have shown that these are all also predictive of later outcomes above and beyond the previously mentioned factors. But as we all know, CT is a volumetric imaging modality. We have three-dimensional data sets, which allows us to volumetrically analyze the amount of plaque in cubic millimeters. As you can see here, we can reconstruct this in 3 dimensions. We can create our multi-planar reconstructions, but we can go one step further and actually quantify how much plaque is in the coronary arteries. And currently, using Hounsfield unit thresholds, we can correlate this with different compositions such as lipid-rich necrotic core or calcification. But for this, you need a software to somehow delineate the coronary arteries. And this is where METIS comes in. So METIS has the QAngio CT suite, which allows basically the delineation of the coronary arteries. As you can see here, it automatically, for example, calculates the inner vessel wall, and then the outer vessel wall is also estimated. This currently is done by a so-called minimal cost approach, which uses specific mathematical algorithms to come up with the result. This is semi-automatic in a sense that these contours may be needed to be edited because we might want a different result. And one of the things I really like about METIS is that they are very much a research company. So as you can see here, they have implemented multiple segmentation algorithms. For example, a soon-to-be published article here uses IBIS as a reference, and you can simply set this segmentation model in the program and segment your coronary arteries using this to get a more IBIS-like result. I had the pleasure to publish an article also using a deep learning method. which automates the plaque segmentation. And this is now also implemented in METIS. It's an open source deep learning model. As you can see here, you can select it. And basically in a couple of seconds, you arrive with a plaque segmentation which was trained on over 3,000 plaques of several hundred individuals. And basically you get the results. This is actually a very hot topic, which is the correct one, and this we could talk about, I think, all day, as we need reference standards in this field to basically objectify our results and make our results comparable between vendors and within vendors also. But as you can see, METIS is a very progressive company and is implementing these new solutions day to day. So we know that volumetric plaque analysis is additive above and beyond stenosis data, adverse plaque characteristics, and there's a huge interest now in this, basically this precision phenotyping of diseases. However, I would argue that we need to go one step further, because plaque volume is only basically a quantification of how many cubic millimeters of plaque you have, and you can then dichotomize that based on Hounsfield unit threshold. But you know that Hounsfield unit thresholds are dependent on various things, such as tube voltage, tube current, the patient characteristics, and so on. And furthermore, it doesn't tell you much about plaque morphology. As you can see here on two images of very different plaques, you can have the same average attenuation, the same plaque volume, same standard deviation. So we need somehow to better describe the morphology of coronary lesions. And this is where radiomics comes in. It's basically a methodology to extract additional features from radiological images, not just coronary CTs, not just CTs. Basically, it's agnostic to the imaging modality, to extract these morphological features that describe texture and shape. And with this, we receive multiple parameters describing our coronary lesions in our case, and which allows us to do further analysis. And I would just like to present two case studies where this might be useful. For example, we always talk about risk factors that cause coronary artery disease. But when we say this, we basically assume that, for example, hypertension or diabetes causes the same kind of coronary artery disease, while I think it's reasonable to assume that this is not the case. For example, why would a coronary artery disease based on dyslipidemia be similar to that based on, for example, hypertension? And the reason is why we think this is that we don't currently analyze enough information from the coronary arteries, and so we only looked at the magnitude, their effect on the magnitude of CAD. However, if we do precision phenotyping with radiomics, we might come to a different conclusion and might be able to differentiate between the effects of different risk factors. And that's what we did basically in a study, a longitudinal study of 300 individuals, where we identified that there were latent morphological features that were only associated with inflammation and those that were only associated with conventional cardiovascular risk factors. So we were basically able to differentiate between the effects of conventional risk factors and inflammatory markers on the morphology of coronary artery disease. And we found that these inflammatory markers, such as cocaine use and HIV infection, result in a different kind of CAD as compared to conventional analysis. We also went one step further and built a open source framework to analyze longitudinally these morphologies, and we came up with a method where you can quantify morphology using longitudinal scans, which is important if you want to, for example, monitor therapies. And in a study where we modeled whether cocaine abstinence causes morphological changes in coronary arteries above and beyond changes in plaque volumes and other characteristics, we were able to describe the plaque morphology using latent features, 20 of them, and with this we were able to identify specific latent features that were only associated with individuals who achieve cocaine abstinence. And then we went one step further and also did network analysis, which is pretty complicated. I won't go into detail, but basically we're able to show that there's a structural change in the radiomic network in those who achieved abstinence as compared to those who did not. So with this, I would just like to show that we can greatly expand the information that is available in the CT images, and not only that, but this allows us to analyze new kinds or use new kind of analytic methods to come up with new conclusions using our existing images that we have. With that, I would like to thank you for your kind attention.
Thank you, that was great. Our fourth speaker, our last speaker of this session, and then we'll have some time for Q&A, will be Carlos Collet. He comes to us from Aalst, Belgium. He's an interventional cardiologist, but really been focusing his career on integrating physiology from imaging. So please.
Thank you very much. Good morning. Perfect. So in the next 10 minutes, I will try to show you how we, interventional cardiologists, are using CT to improve the outcomes of the patients that are undergoing PCI. To do that, we have coined this term in the last couple of years that we call CT-guided PCI, which actually provides a framework to incorporate the CT in the lab. So by disclosures. So the first thing that we realized, and we realized this a few years ago, is that when we are facing this type of disease and you are in the diagnostic setting and you ask, for example, Joao, who's in the audience, what do you think about this case? He will start looking at this case from the diagnostic perspective. He will start thinking, this is probably obstructive disease. It's very difficult, Carlos, because there's a lot of calcium. The cross-section, I cannot see anything. Maybe yes, maybe no. I'm not sure. But if you ask me what I'm thinking about different things. If I'm going to have this patient in the lab, I'm thinking, where is the rota machine? Where is the nurse with the rota thing? Bring the connectors. I'll probably need some special balloons to be able to treat this case. So we realized pretty soon that one image have two different interpretations. And this is how we are looking at these pictures. I mean, not pretty well. We have described that CT today is able to characterize all this type of plaques morphology from the early phase to the late fibroateroma. But what is very important for us is the fact that CT is able also to define calcium. And we don't see calcium as a problem in the image. We see calcium, there is calcium. Tell me more about the calcium. So it's kind of, it's very interesting, the interaction. And we can not only look at the calcium itself, we can see the arc, we can see the thickness, we can see the length, and it correlates pretty well with invasive imaging. This is one of our preliminary works looking only at calcium. And we decided to use OCT because it's a light-based intravascular image modality that allows to calculate the calcium volume. So what you see here is in the x-axis, the calcium volume derives from CT, and in the y-axis, the calcium volume derived from OCT. And you see the correlation on the screen, but I just want to focus your attention on the slope of this fit line, which is 1.6. This actually means that CT is able to really assess calcium, but it overestimates the calcium volume by 60%. So with that in mind, we took the next step, which is incorporating this inside the cath lab. And this is what I'm going to show you today. So this is a typical coronary angiography. You see here a severe lesion in the left anterior descending artery, but we don't know what is behind that stenosis. And we have doing this work and putting stents like this for the last 20, 40 years. Now, having the CT next to you inform you not only that there is a severe lesion, but what is the composition of that lesion. And you can imagine that calcified plaques are treated differently from non-calcific plaque. But the next hurdle that we found, and I know how to read CT because of a number of anecdotes in my life, but this is not the case for the majority of the interventional cardiologists. And so in my lab, my colleagues don't know where the CT is located, and this is true for many hospitals. So it's like a maze to get from the CT to the cath lab. So we work a lot on bridging this gap. And here where Medis came along, and we start discussing this with Peter 5, 7 years ago, more or less. And then we start coming with solutions. And the solution was, we don't know how to read these images. This is for the imagers. This is for the radiologists. We need something more fast, easy, that we can look at it, it's intuitive, and then we know what it is. So we start making mesh of the lumen, and we decided, why don't we put the plaque on top of it? And then we start putting the plaque on top of these meshes, and we find this is the final model. And you see here that is very quickly the interpretation of this, and it will take you 10 seconds to understand that the white is calcium, that the red is the blood, and you see all this non-calcific plaque in green. And why is this important? Because we see this live, and this is, in my view, the first time that we can assess coronary artery disease in 3 dimensions. And for us, it's important. Why? I'm going to show you how we finally use these images. This is a video. Let me see if I can play it. So this is my cath lab in-house, and the images are actually integrated in the lab, and they are synchronized with the C-arm. So every time that we move the C-arm, these geometries move along. And what that actually gives you is that before you even put your foot on the pedal and you give contrast, you know exactly what you're going to see. But it's not only that, it's that you're being informed about plaque composition that actually the angiography doesn't tell you what that is. So this is the solution. This is, again, a video that helps you understanding not only the 3-dimensionality of the plaque, but also provides you a correlation between the calcific plaque and side branches, and for us that is crucial because when we treat bifurcations, we can understand how the side branch will interact. In addition to that, we have also in the software, this is incorporated in the lab, measurements tool, so it's also the first time that we can measure length of disease in the 3-dimensional space, and that happens again live inside the cath lab. We are aware that to push this concept forward, we need evidence. So we have designed and we're conducting a randomized clinical trial. This is a large trial involving 1,000 patients where patients referred to the cath lab with significant coronary artery disease will be randomized to 2 groups. One group is the CT-guided PCI, and I'm going to explain in detail what that actually means. And the control group is what we believe is today the state-of-the-art PCI, which is IVUS-guided PCI. This is a non-inferiority trial with MACE as an endpoint at 1 year. What is CT-guided PCI? And this is what we believe all the information or most of the information that you can extract from a CT that is relevant to a PCI procedure. And it starts with understanding the 3-dimensional tree, to understand the distribution of disease, the ostium, the lesion length, the myocardial mass at risk, which is crucial in cases of bifurcations as well. And in the trial, we're also using the solutions provided by HeartFlow in terms of computational fluid dynamics. What the concept behind CT-guided PCI is the fact that for the first time, we know exactly what we're going to find. So the first word is the key, plan. So we enter the cath lab understanding exactly what we're going to find, then we follow an algorithm, and we finish with the optimization based on angiographic enhancements tool. This is how it looks. This is a live case performed a couple of weeks ago for New York, and this is actually in front of me, and I'm just measuring the stent length and understanding a lot of technical details that will happen after putting my stent concerning that calcific plaque in the middle. At the end of the day, this is what we have. So this is the information that we combined for the trial. So of course we have the conventional angiography. In addition to that, we have the 3D plaque morphology, and of course we also have physiology. So as a conclusion, coronary CT complements invasive angiography by informing about the plaque volume, extension, and composition. The integration of the CT real-time is today a reality. It's available, I can say, in almost 20 cath labs in the world that are participating in the trial. And we think that this approach will improve clinical outcomes. In the next decade, I think that coronary CTA will become a tool for interventional cardiologists to plan PCI. Thank you very much for your attention.